Hi, everyone. Thank you for tuning in, and welcome to our webinar on driving value through patient engagement. We are just going to give everyone one more minute here to join us before we kick off together. All right. So we've got a great crowd, so we'll go ahead and kick off. Thank you again for joining us. Wanted to welcome you to our webinar. Our topic is driving value through patient engagement. We've prepared a really great knowledge share session for FQHC and health center leaders. Today, you will be learning how Lone Star Circle of Care addresses population health through strategic outreach messaging. Before we go into introductions, just a few notes on today's agenda. So we will have a presentation for about 30 to 35 minutes, followed by a Q&A session. We welcome you to engage throughout the presentation and to share your questions via the chat. However, we're going to come back to those questions at the end of our session today. Now to introductions. My name is Gia Charles. I'm the head of marketing at CareMessage. And I wanted to say thank you to everyone for joining us today. We see great representation from health centers across the country. And we also wanted to say thank you to Jane Havezi, Senior Program Officer at Methodist Healthcare Ministries, for co-hosting today's webinar together with CareMessage. And last but not least, I wanted to say a warm thank you to Dr. Tracy Angelocci, the Chief Medical Information Officer at Lone Star Circle of Care. Thank you, Tracy, for sharing your story today and leading our webinar. Tracy has been the Chief Medical Information Officer at Lone Star for almost 8 years, and she leads the clinical analytics team and population health team. So without further ado, I'll hand it over to Tracy.
Thank you, Gia, and good afternoon, everyone. Thanks for joining us today. I know everybody's schedules are crazy busy, and I first want to say that I appreciate the work that all of your health centers are doing. This is a really challenging time in medicine where consumer-driven healthcare is intersecting with value-based contracting, and now we're moving into downside risk. I'm actually encouraged by what that ultimately will mean for all of our patients, but it's definitely a lot to wrap our arms around as we begin to change our models of healthcare delivery. But all of the new models of healthcare delivery that we're moving into require increased patient engagement, and that's what we're talking about today. If I can move. Okay. So first, just a quick note about Lone Star Circle of Care. We are a federally qualified health center in Central and Southeast Texas with 20 clinics that span 6 counties. We employ just shy of 130 providers and care for 85,000 unique patients annually. And we have all of the main primary care lines of business, including integrated behavioral health, plus dentistry and optometry. So quality care is super important to us. We are Joint Commission accredited in both ambulatory and behavioral health care, and we're also PCMH recognized. We're actually currently transitioning from NCQA to Joint Commission on PCMH. So we're in the unique position for this year only of being recognized PCMH by both entities. And based on quality metric scores, we've been recognized by HRSA as a health center quality leader for each of the past 5 years and rank in the top 10% of all FQHCs for the past 2 years. And in 2015, we also earned HRSA's National Quality Leader Award in pre and perinatal care, which is an award generally reserved for the top 1 to 2%. So I'm throwing up our mission and vision here specifically because they relate to the topic that we're talking about today. Our mission at Lone Star is to provide exceptional and accessible care. Yet to a large degree, we still care for patients within the 4 walls of our buildings, and our patients have to run the gauntlet of a call center to even get within inside those 4 walls. And I don't think that's anybody's definition of accessible. So we are looking at a variety of ways to expand our reach outside of the four walls and to be proactive and reach out to the patients as opposed to just waiting for them to try to get into us. And our vision is to eliminate health inequalities, but we know that our patients have all kinds of economic inequalities that make their ability to communicate and interact with us more difficult at times. We believe that a texting communication platform increases both our accessibility to our patients and helps reduce those communication inequalities. There's some interesting stats that I put up here on the slide from Pew Research that just came out earlier this year, and they show that nearly half of people who earn under $30,000 per year do not have broadband access or a computer at home, and 29% don't have a smartphone. So those are really important stats to pay attention to if your mobile communication strategy is limited to a patient portal or some encrypted messaging platform that requires a data plan. So I think we all kind of know that our patients are probably communicating mostly by phone with us, using their phone as a computer, but we do need to remember that potentially up to nearly a third of them may not have access to a data plan or be able to access web-based things. So patient portals may not be the best avenue for reaching them. So what we're going to talk about today is just a really fast overview of the phased approach that Lone Star has taken into value-based contracting, and then spend the majority of our time talking about some text messaging strategies that we're doing today. And then finally, we'll wrap it up with showing you some of the impact that those text campaigns have had, and talk a little bit about some exciting future uses that we have planned for texting. So our transition into value-based care really started 8 years ago when we entered into our first ACO contract. And for us, phase one was really all about measuring. We formed a clinical analytics team at that time, and it was all about metrics, data architecture, writing dozens and dozens of metrics, delivering the results of those metrics in near real time to where all staff could access and see how we were performing. And we were really trying to empower the clinical teams, the people that were at the point of care with the clinics during phase one. So one of the primary things that we did was develop a custom point of care tool where it was one click inside of the EHR would pull up the metrics that were applicable to that patient was currently failing. And I know a lot of EHRs do that now, but they were not doing that 8 years ago. And we also had a very customized version of the EHR, so we couldn't use the reporting directly out of the EHR and needed to build something custom. But that did help us close a lot of the care gaps. So if the patient showed up for a visit, it was basically do these things, do all the things that they are overdue for. And then we supported those efforts by some other things that we were doing to decrease the no-show rate. So get the patients in, take care of why they're there, and then do all these other things that the patient is currently failing. And there was definitely accountability around that. A couple years into it, we built provider scorecards, and then 2 years after that, added medical assistant scorecards. All of our scorecards are transparent. Everybody can see everybody else's scores. And the MA scorecards have paired metrics with the providers. So they're both responsible for the same metrics, trying to really encourage that teamwork and that team-based care. And the transparency definitely promotes some healthy competition. And then in recent years, we were able to add rewards in terms of financial incentives to providers and MAs based on their scores on their scorecards. Then phase two really probably happened about 3 years ago when we added a layer of centralized support. We formed a population health team, and this may not be population health in the way that everybody thinks about it. It's not into case management, and currently it's not even actually managing our entire population of 85,000 patients, but they were formed specifically to help us perform well on pay-for-performance contracts. So they manage all of the metrics for those contracts. We still try to push as much as we can at the point of care, but if a patient's not showing up for a visit, this team gets them in for a visit or closes gaps without a visit if possible. They do a lot of screenings by phone. They have standing orders that allow them to order lab work, schedule lab-only visits, schedule diagnostics like mammograms. They also do a lot of work scrubbing outside records, like from the hospitals or other outside entities, sort of looking for those elusive mammograms and colonoscopies. During phase 2, we were involved in meaningful use as well, and we did add a patient portal during that time, but that's not really driving our efforts. We have about a 15% engagement rate with patients in the portal. And then phase 3 is kind of where we're at right now. We are in next year moving to downside risk in some of our contracts, and sort of our mantra right now is personalized healthcare delivery. Like, do whatever it will take to drive engagement with the patient. That may be texting, that may be, we have one of our clinics operating as a convenience care model right now, walk in 7 days a week, no appointment needed, that sort of thing. We're doing a trial right now with e-consults, moving into just sort of planning primary care telemedicine for later this year, and even talking about mobile care delivery. We know as we come to the end of some contracts and we're missing a metric, by a handful of patients, and we just need labs on them, we have put nurses in cars and sent them out to patients' homes to get blood. And so we're just kind of looking at it now as like, why do we do that as sort of last-ditch effort? We should really start to sort of plan some sort of mobile care delivery into our overall strategy. And then the other thing that we're working on is having the population health team spread these pilots that have worked for us in pay-for-performance contracts to the generalized population of Lone Star. Also, as we move into some of our managed Medicaid pay-for-performance contracts, we need to really focus on patients who have been attributed to us but have never established care at Lone Star, because they're currently counting against us in our metrics. So we're focusing on how to reach and engage those attributed patients and get them to come in. We're also currently overhauling our data warehouse to incorporate different types of data: cost, risk stratification, social determinants of health, and really just trying to figure out now whether we need to add expertise on our team that is true deep case management for the high utilizers and high cost patients. So as the population health team has done all of this over the past couple of years, we have a lot of communication challenges, and I'm sure none of these are unique to us. But phone calls are time intensive. They're inefficient. We only reach our patient about 50% of the time. Even when we reach the patient, we're not always reaching somebody who's really wanting to engage in a conversation at that time. It requires synchronicity. The patient and us need to be available at the same time, which is generally 8 to 5, Monday through Friday. And a lot of our patients are working, and that's just not a good time to reach them. We have tried a secure messaging app specifically related to program registration. So when a patient is new to Lone Star, they first have to go through program registration to see if they qualify for Medicaid or some county indigent payers or that sort of thing. And we tried to move that all away from an in-person visit to working through a specific app where they could take pictures of like their pay stub and their driver's license and that sort of thing. And we have had not great uptake with that. Probably less than 20% of our patients complete program registration through the app. Again, it does require them to have a home computer or a data plan on their phone. Patients were suspicious of the text or the email that would come to them inviting them to do this. It looked like spam or phishing to them. So it to us felt very similar to Portal with that low 15% patient engagement rate. And mailed letters, we pretty much gave up on that a long time ago. It's just expensive and ineffective. So we needed to find something else that would help us with those. So the opportunity that we saw with CareMessage text platform is a way for that population health team to still improve those patient outcomes, achieve the quality metrics that increase our reimbursement on those contracts, to drive operational efficiency so they can be reaching hundreds or thousands of patients at a time as opposed to the manual one-on-one phone calls, and automate some of their outreach workflows. And then hopefully increase patient satisfaction. I know that I would probably rather respond to a text than a phone call, at least on some days, and staff satisfaction, because it's hard to walk out of here after a whole day of calling patients nonstop and not reaching many people, or having the people not be very excited to talk to you once you do reach them. So we looked around in the market for text-based platforms. Very specifically, Plain SMS texting, because of our experience with the patients not really engaging with us on that, that secure messaging app that we had, we wanted just plain texting. And we found CareMessage, and we originally had a grant that funded us to employ CareMessage for 15,000 patients. That was just July of last year, so it hasn't even been a whole year yet. And we were seeing enough effectiveness of that we actually expanded our coverage in February of this year to our entire patient population. So the Pop Health team is harnessing automation. We'll talk about like campaign, sort of mass campaign texts. But as well, they can engage patients in a personalized way with one-on-one direct messaging. It's really intuitive. It's texting. I mean, who doesn't know how to text? I will say that my mother-in-law still will not text, but most of our patients will. So it's very intuitive. And importantly, it's asynchronous. So we can text before we leave in the daytime, and during the night, the patient can text us back and we can reply the next day. The other thing that was interesting to us about CareMessage is they have a comprehensive patient engagement with these preventive care programs. So they're context-based. So think about a diabetic needing diabetic education, a woman who's in her prenatal or postpartum period, a patient who's desiring to quit smoking, those sort of programs that deliver an average of 2 texts per week over a period of several weeks up to 6 months. They're educational, there's a motivation, sort of engagement component to them. And then for patients who do have a data plan or Wi-Fi access, some of those texts will contain links that will take the patient out to more expansive information on that topic. So we do use the direct one-to-one patient texting rather than the big campaign blast in certain situations. Really when we're needing to really engage a certain patient, either they're a high need, like they are just recently discharged from the hospital, maybe abnormal lab patients that we can't reach. Our population health team manages an abnormal PAP registry, and they use texting quite a bit to keep those women in the loop of getting the follow-up testing that they need. If we are reaching out to a patient and we're not wanting them to call our main call center, because that's primarily staffed by patient service reps who mostly schedule appointments. But if we're needing them to talk to one of our nurses or really engage them in a much deeper level, we are likely to text them and get them to text us back or give them a direct line where they can reach the population health team. Then there's some patients who fall into very narrow time frames where we're trying to get them in, like the 21 to 56 day postpartum period. There's lots of metrics we need to meet during that time frame, or that first like 6 to 9 months of a child's life where they're needing to come in every 2 months for well child checks. We have a lot of success in engaging patients kind of right when we need them with direct one-on-one texting during that time. And then of course, people who still have care gaps despite the mass campaign text, if they're not responding to it, we will try a direct, more personalized approach with one-to-one. So here's an example of an actual outreach campaign that we've done. Now this is the blast campaign that you can set to go out to a lot of people, and those campaigns allow you to set your text with a yes/no response or kind of a multiple choice ABCD response. So you're sending some message out to the patient, and then depending on what they text back, they receive additional information. So this is a good example of an outreach for annual well child checks that is personalized to a very specific population. This would be our Blue Cross Blue Shield members, and we're able to advertise specific value-added services that we're not paying for, but Blue Cross Blue Shield is. And those patients can earn $50 grocery store or $75 Amazon gift cards for keeping their yearly well child check. So we send a message out telling them that, because I know the managed care plans send a lot of information to the patients, and the patients should be aware of these value-added services, but they usually are not. So it's sort of the what's in it for me, you know, why should I do this and come in and get this physical done? So we're presenting it right there in the message, trying to sort of grab them, hook them. And it says type yes for info. So if they say yes, we go into a little bit more detail about getting the cards. We take care of all of that for them, reporting back to Blue Cross Blue Shield so that the cards are sent out without the patient having to do anything. And then this response also allows us to give them an additional way to reach us. So in the first text, we gave them a phone number. In the second text, we're giving them, our population health team has a variety of specific email accounts that they handle, because of course we can deliver a lot more information via email because we don't have a character limit that we do with text. So we would have a big Blue Cross Blue Shield email set up that describes all value-added services that they're eligible for. And then here's another example of cancer screening outreach for mammogram. This particular message went to MAP. Medical Access Program is a county indigent program in one of our counties here. So we are sending a message to patients saying, hey, good news, MAP patients can now get free screening mammograms at Austin Radiology. Can we send in an order for you? And again, our population health team is empowered with standing orders, so they are able to go ahead and initiate these orders for the patients. And you can see in the yes and even in the no responses, if the patient would type no back, we're still giving them information about the fact that they should be screened every 2 years, and we're still here for them when they're ready to schedule. But you can see in this one trial where we texted 122 patients, about 15% responded back, but the majority of those, 76%, said, yeah, schedule me for that mammogram. And those are patients that obviously they've been coming to clinic and everything, and we had missed them and they weren't getting scheduled prior to this text. Here's another example of a text outreach for disease management. This one's specifically related to diabetes and getting annual retinal eye exams. So we sent a message out saying, save your vision, diabetics need an eye exam every year. LSCC, that's us, Lone Star, has added eye cameras to some of our locations. Would you like more information? Type yes or no. So those yeses, we're making sure that they're getting scheduled, and the nos are, again, getting some more patient education about why it's important to be screened. And again, this one had almost a 22% response rate, and the majority, 83%, are saying, yeah, I want to get in and get that eye exam. And then this is an example of a specific pay-for-performance contract that we had, and one of the metrics was looking at influenza immunization rates. And this, typically on our metrics, we don't take patient reports of anything, we require proof, but this particular pay-for-performance contract allowed patient self-reporting. So if the patient said that they had a flu shot somewhere during this flu season, they got numerator credit. So it was near the end of the contract year, and we weren't quite reaching that metric. So we sent out a message to those patients who were failing to say, hey, have you gotten your flu shot this season? Text yes or no. And if they texted back yes, we'd like, great, when and where did you get it? And then we would transfer this information over into the chart. So in the EHR, we had some proof that the patient said, yes, I have gotten this done. So again, more than a quarter of the patients responded to this, and half of them had had the flu shot. So this helped us meet that metric for that contract. And again, through great automation, one text going out to almost 750 patients. And then just it's super easy in the CareMessage console to sort of cull through those answers and look for the ones where patients had said yes. We currently have a couple experiments going on with colon cancer screening, and this is related to patients returning the IFOB kit, which is the take-home kit where they do a self-test for colorectal cancer screening. So we have two different experiments going on, and we have some texting related to that. In 2 clinics, we are going out and retraining the MAs in those clinics. So if the provider says, hey, give this patient an IFOB to take home, instead of just sort of handing it and maybe doing a cursory explanation, that we have a whole kit that includes a little plastic body with a lift-up lid and an actual kit that we take out. So we go through the whole visual explanation, making sure that there's no sort of like when a patient gets home and they open the IFOB kit, there can be a little bit of a freak out because there's this really long, explanation, and they might feel like they're not doing it wrong, or it's just too complicated and I don't want to read it. So we're making sure that the patient, A, understands the importance of colorectal cancer screening, and B, really, really knows how to do this kit before we give it to them. They take it home, it's stamped and self-addressed, so they can just drop it in the mail when they're done. But half of that patient cohort is going to be randomized to receive text messages every other day times 3 messages in the week right after they take home the kit. to see if that increases the return rate. Then we have a whole separate project going on right now where we have taken a certain subset of patients that are part of a district contract for us who are currently overdue for colorectal cancer screening, and we just mailed them IFOB kits. It's unrequested by the patient, it's unexpected by the patient, and it comes with a lot of education and how to do it and return the kit to us. But the two cohorts is one will receive a text message a few days before receiving the package from us, and then also a week after receiving the package from us. The second cohort is just receiving the mailing with no text messaging. So kind of excited to see what happens with those two studies that we've got going on right now. So the impact that we've seen is definitely operational efficiency. I think you've seen that in some of the very specific examples we just went through, where literally one blast reaches 750 patients and a quarter of them respond back to us. Compare that to sort of what it would be like on phone outreach. There is definitely a large group of patients, especially the ones who are on one-to-one direct text messaging with us, who are super happy. They don't have to get on the phone and go through the call center and all of that. So at least for that subset of patients, I think there is definite improved patient satisfaction, and our staff really, really enjoys this method of communication with the patient. And of course, through the studies that I just showed you, we've definitely been able to close some of those gaps and gain additional revenue on some of our pay-for-performance contracts. So kind of what we're looking for in terms of expansion over this next year is when we first got this last July, we rolled it out, I gave it to the population health team. We had a lot of other projects going on, so I just kind of let them sort of take it and play with it however they wanted to. But now that we're seeing like some real returns from it, we're now in a mode where we're developing a true cohesive patient engagement strategy where all the campaigns are scheduled out, for a full year. Lots of new use cases are coming up, like engaging those people who are attributed to us but have never been to Lone Star, potentially having the patients help us close the loop on those open referrals that we're not sure if they ever got done or not. Definitely expanding our outreach to the full patient population as opposed to just the subset that is a part of some pay-for-performance contract. And looking into expanding the use to other staffing groups. Right now, I really just have the population health team using CareMessage, but we're thinking about expanding that into the clinics where, for example, front desk could do an immediate text follow-up on a no-show or something like that. And then one of the things when I was talking to CareMessage staff about doing a presentation is I said, gosh, I'm a chief medical information officer. I'm all about data. And I feel like a lot of the stuff that we've done in this year is anecdotal, although there's some good numbers there in those anecdotal reports. So what we're moving towards right now is truly developing a metric standard in a data collection process where we are going to actually do more of the studies like the last two examples I showed you with the colon cancer screening to really try to measure the ROI. That can be a little bit difficult to tease out because some of these patients, it is critical if they're part of some contract that we're probably outreaching to them via multiple methods. So just trying to tease out how much of the response is really due to texting versus anything else. We have a really interesting pilot, a year-long pilot going right now with well child checks, where we had a couple years, we would always do a big push every summer to try to get all our kids in for well child checks. Several years ago, it was just a robocall campaign, and it had a 4% response rate, meaning 4% actually scheduled and kept appointments from that. We then moved to a live calling method the following year, but each patient or household would just get one phone call, and that gave us an 11% response rate. Last year, we have a new call center software that lets me feed outbound call campaigns and kind of blended inbound, outbound calls. So when I have service reps sitting there on the phone and there's no inbound call to take, it feeds them up an outbound call. But those patients would be called a total of 3 times, and that increased our response rate to 24%. But it's heavily staff intensive, right, to make all of those manual calls. So this year we have multiple cohorts that we're studying all year long, and some of those cohorts are only receiving text. or text and email from us. So again, super interested to see where that all lands at the end of this year as we really try to tease out the real ROI. I think it's there. I think anecdotally we see it, but really interested to get sort of some hard data around that over this next year. And that's really all I've got. I wanted to definitely make sure that we save time for Q&A.
Fantastic. Thank you so much, Tracy, just for a wonderful presentation. I think I can speak on behalf of all of us attending that had some just really great insights and takeaways. And thank you also to audience for engaging. We do see a few questions, so let's dive right in and go through some of those. Just see if I can actually bring that up. You know what? I'm actually going to ask for some support from Jessica on the team to help us go through some of the questions. And also, let me make a brief introduction. So Tracy's on hand to answer any questions that you might have about the presentation, the anecdotes she shared. For any questions that are more CareMessage specific, we also have Mike Halen, our VP of Sales, on call to jump into those as well. So Jessica, I'll let you kind of take it from here.
Perfect. Thank you for the intro. So our first question came from Alicia. She didn't catch which EHR that you're using. So just wanted you to clarify that for her.
We are on NextGen.
Perfect. And a lot of people are asking if the presentation will be available after our webinar today, and we will be sending that around to all registrants via email tomorrow morning. So you will have a recording of the presentation tomorrow. Great. The next question came from Michelle, and she asked for the name of the grant that's funding your text program, as well as who does your population health team consist of?
The grant was from a foundation, Episcopal Health Foundation, and it was part of it wasn't a grant specifically for text messaging. It was to reach a larger population, and in our grant proposal, we proposed that texting was one of the many things we were going to do with that population. The population health team consists of 6 people. There are 3 RNs, 1 LVN, 1 MA, and 1 non-clinically certified assistant.
Perfect. And then and feel free to keep sending questions in, everyone. If we don't get to all of the questions, then we'll follow up personally with each of you. We might not be able to get through all of them. But the next question came from, let's see, Leslie Pelkey, who said, is it clear that your text is from Lone Star?
Yes, the system is set up that whenever we enter someone into the system, it automatically sends an initial message out explaining who it's from and gives them, type stop to opt out.
Perfect. And then the next question came from Cami, who was curious what you have done to identify, collect, and maintain your patient's cell phone numbers.
At various times, we've actually run competitions in our patient navigation center because they're the ones taking all the intake calls for appointments, and we'll run the percentage of each agent's appointment scheduled for that day, the percentage that have cell phone on file. We, of course, like I'm sure a lot of you have patients who use temporary phones and their phone numbers change. Our really only avenues for increasing that is when they're calling to schedule an appointment or they're showing up in the clinic for an appointment. We're verifying demographics, including cell phone number.
Perfect. I think the next question I'll go and direct to Michael Halen, our VP of Sales, just around Muhammad asked about the process of CareMessage being integrated into NextGen, and just what that if it's a manual process or what type of integration exists.
Thanks, Jess. Yeah, and hi everybody. Unfortunately, it does depend on the EMR. there are various levels of integration that we support depending on the EMR. At a minimum, most of our integrations include bidirectional appointment reminders to confirm and cancel appointments. When we're talking about most of the scenarios that Tracy has covered today, it would depend on your EMR. So we're happy to follow up individually after this, and we'll be making sure we've done so through all the questions that are posted here.
So I would just like to add to that we actually don't have an integration right now. So an integration, of course, would be super important if you were using CareMessage for the appointment reminder function. But in our trial period this year, since we're really just using it for population health, we actually don't have an integration. So when we're ready to send out like a blast campaign, or here's a subset population that we're following who we might be doing direct one-to-one messages to, it's very easy. We just pull, our analytics team pulls a report of those patients into Excel, and we just feed it via Excel directly into CareMessage. There's a minimum number of fields like name, date of birth, a unique number like a medical record number, and cell phone number that we feed in. So it's really easy to populate it even without an interface.
Perfect. Thanks for that addition, Tracy. And we're getting a lot of questions around just patient consent and maybe HIPAA concerns as well. And, are text messages secured when patients are sharing information? So Tracy, if you wouldn't mind just sharing a little bit about that process on, giving patients the option to opt out and how you guys have handled patient consent and things of that nature.
Yes, so within the CareMessage platform, the very first text that a patient gets instructs, how to opt out by typing stop back, and for any text that they get, they can type stop, and then the system knows that that patient has opted out. So even if I load a new text message to go out to that patient, it won't send because the text consent is kept inside of CareMessage. For HIPAA concerns, so yes, text in transport is not encrypted, but it's not, it is still HIPAA compliant as long as the patient has agreed to communicate in that method. The other thing we do to sort of further protect ourselves is that not so much in one-to-one messaging, because we really have a relationship with that patient we're texting with at that point in time, but more for the broadcast, like mass text campaigns. We tend to limit those to preventive health, so like immunizations, cancer screenings, annual well checks, that kind of thing, and not disease-specific things like, hey, you're a diabetic, you need this thing done. We kind of rein that into very specific populations if we're talking about disease-specific things.
Perfect. Thank you, Tracy, for answering all these, kind of firing away at you. Really appreciate it. And I'm sure everyone else does as well. We'll do probably 2 to 3 more questions before we wrap up. But the next question would just be around kind of team enablement and how you really deployed CareMessage at Lone Star Circle of Care. Like, what was the process in, getting your team to sign on, onboarding them, excuse my text sound, and just deploying that at all of your sites, like what that process looked like for you guys.
So right now we're still just using it with the population health team, which is all centralized in one location. We haven't opened up the use of CareMessage to the clinics yet. So training was really easy because they were all here together. It really is, so especially the direct one-to-one messaging, it's like an inbox. It's a very user-friendly interface with CareMessage, so it was super easy to teach them how to use it. I'm a little more careful with the blast messages just because they, potentially go out to many thousands of patients at a time. And we have one member of the team who has a very technical mindset, and we've trained her to do that. And you can set permissions on the back end for who can do blast messages. She's also the one who takes care of all of our blast email campaigns as well.
Perfect. Now I'm actually going to direct, since I'm trying to bucket some of the questions together, but a couple of people are just asking around the cost of CareMessage. So maybe Mike, if you want to jump in once more, just to give a little bit more detail around the pricing of CareMessage could be helpful for people listening.
Sure, I'll talk about just generally how we price CareMessage, and then if you have specific questions about exact cost for you or your health center, we'd be happy to follow up with our team. So CareMessage tries to approach pricing from a really transparent perspective and one that is hopefully easily understood, just based on the total number of patients that you serve. We center that around the UDS data that's publicly available, of course. And then the only additional patients that could be factored in would be those that are getting reached out to that are unengaged or members without visits. That would be incremental to whatever your UDS data posts. And so it's generally in 10,000 increments. So with every 10,000 that you scale, the per patient cost goes down. And that includes, that cost includes all of our available functionality and services, including something that's really unique to us, which is unlimited text messaging. We believe strongly that empowering you to send as many messages as possible is both to yours and your patient's benefit. We've certainly seen that borne out with Lone Star Circle of Care, and we don't want you to feel like you're getting nickeled and dimed for every message that goes out, because we believe that that has an adverse effect on the success. On the services side, we include all those as well. We dedicate a customer success manager. We have a support team that has in-app support. So if you're working on an outreach message and you have a question right on the spot, you can have access to someone immediately. And we try to center everything around your goals. So really developing a deep understanding of the quality measures that you have to hit, no-show reductions, goals that you might have, and even long-term chronic condition management through diabetes, hypertension, or other chronic conditions your population faces, to ensure that we're centering the work that we do, making it as easy as possible for you to deploy these programs, including offering things up like patient engagement calendar that really prescribe to you month over month. What are the messages that we've seen other QHCs use successfully to make it easy for you to do the same? And of course, all the content that comes with that, pre-translated.
I would just echo what Mike was saying about the your account reps. They have been amazing. They really do care about what are your goals, why are you deploying text messaging, and helping you come up with ways to measure whether you're actually reaching those goals. I call my account rep my accountability partner, because I have so many projects going on that I rely on him to keep me on track and keep building out the engagement schedule that we're working on right now.
Perfect. All right, we have time. We'll squeeze in one more question. So I know we have a minute left, but Tracy, you mentioned a patient engagement schedule for outreach. Can you just elaborate more on your plan, maybe especially for health centers that are thinking about implementing texting for the first time?
Yeah, so I think originally when it started, it was just the day-to-day work. When you're down in the weeds, you sort of lose sight of the big vision. And I noticed we were doing tons and tons of like one-on-one direct messaging. And we had done, a blast campaign for pap smears and stuff like that, but we hadn't done a lot of blast messages. So we sat down and planned out for the calendar year, the different types of, like when flu season would come, we're going to do those, annual well child checks, especially in the summertime, cancer screenings, that sort of thing, like scheduled it out so that we weren't coming to the end of the year and going, oh gosh, we haven't done these and we need to hit some of these, and then bombarding patients with texts. So really just trying to piecemeal it out so they're not getting really too many texts, especially of the campaign type, because I don't want to encourage them to opt out if they were getting too many messages. And then one by one, we just looked at each of our pay-for-performance contracts, the metrics that we needed to hit, and see if they would align with that big strategy, like we can just let the mass campaign go, or do we need to do some very specific text to just that sub-segment?
Wonderful. Well, that brings us to the end of our webinar today. Thank you again, Tracy, just for a really, really wonderful presentation. And a big thank you also for all of you for joining our session today. As Jessica had shared earlier, we are going to be sending an email to everyone so that you'll have reporting with the presentation slides to refer back to, and you're welcome to share with any colleagues or teammates. For any questions we weren't able to address, we'll also be following up with you directly. And we welcome you to also feel free to reach out directly to Jessica Day at CareMessage if you have any additional emails. Thank you again, and please enjoy the rest of your day.